Okay, so this presentation describes a couple clinical lessons regarding patellofemoral pain and arthrogenic inhibition of the quadriceps. So first, arthrogenic inhibition simply means that the muscle, in this case the quadricep, on the anterior aspect or the front of the thigh, is inhibited secondary to the altered afferent and nociceptive, that is to say the painful stimulus that is coming from the joint itself. So it can be difficult to volitionally and reflexively engage the quadricep after knee injury and or surgery. In this case,
So looking at NMES using the Power Dot 2.0 for the quadricep, same amount of...
Even in the presence of artificial stimulation, notice the threshold that is necessary in order to induce a tetanic contraction of the quadriceps from side to side. You're looking at the right limb here that is the involved.
So looking at NMES using the Power Dot 2.0 for the quadricep, same amount of stimulation from one side to the next. On this uninvolved side, you can see how reactive the muscle is to the stimulation versus even on the involved side, there's same stimulation yet much less muscle activity, which speaks to the inhibition that we're seeing within the quadricep. And this is non-volitional. This is in a warm-up setting prior to the actual volitional engagement on top of the NMES.
Not only can the quadricep itself be inhibited secondary to the afferent and nociceptive input from the joint itself, but specific portions can be biased. We see the example in the manifestation of asymmetrical quadricep activation in this patient here.
Been consistent throughout.
Watch as she describes the differences between limbs as well as within the limb as far as the distribution of her tension in the soft tissue.
Yep.
Yeah, but it's like firm. Yeah.
Mm-hmm.
And then this side is like squishy. And there's like, it feels like knots. And you can see it kind of like pop when I roll my, and sometimes it feels like sore.
Mm-hmm. On the outside there.
Yeah.
What about on the inside of your quad?
It feels like also super like soft.
Yep.
But there's no like knots or the same feeling that I have over here.
Exactly, well described. So she has fullness and good resting tone within the muscle on the right limb, which is the uninvolved, and on here on the left, she is getting this lack of tone at rest, but then in particular the vastus lateralis is doing the majority of the work as well as the intermedialis, hence the asymmetry that she describes with the bumpiness and or the trigger points that she's developing asymmetrically throughout the quadriceps. So how does this play out from a functional standpoint?
Been consistent throughout.
Yep.
So let's just examine the differences in these examples that she provides.
Yep. All the way up as much as you can. Okay, and what do you feel?
Like a pull, like right here.
So this is a simple test to look at the full quadriceps competency. Really no vector of gravity is working on the limb. The patient is simply trying to fully straighten the leg. And this is without, though the stim pads are on, there's no current.
Okay. Okay, so with the stim, with the normal pad placement, you get much better extension. Yep. All the way up as much as you can. Okay, and what do you feel?
Like a pull, like right here.
Okay.
And then
Okay, so with the stem, with the normal pad placement, you get much better extension.
it sort of feels like the same.
So with the classic pad placement, she's still getting an asymmetrical recruitment within the quadricep muscle, producing a slightly biased lateral vector of muscle force when she contracts the quadricep. Hence the medial pull that she feels over the reconstructed area, over the MPFL and the medial retinaculum. So what is the solution?
Same pull, but it's easier to get my knee up.
Okay, so same pull, again, medial aspect.
Yeah, like right here.
Got it. And slow, how well can you control that back down?
When it's activated or not activated?
When it's, either way.
Like it's off right now.
Yeah. And you're okay controlling it.
Yeah.
Great. Any knee symptoms coming down?
Would you do this?
Okay, I'm gonna try one more time.
Yep.
Is it wise to do that?
No. No symptoms.
Great.
Yes. Is it about your test?
So changing the pad
Oh,
placement,
that it hurts.
okay, to more of a medial bias.
Great. Yeah. Good. Okay.
All right, tell me what you mean by it hurts.
Oh, like it's just like the normal like E-stim.
Oh, okay.
Yeah.
And then go through a couple reps and just compare and contrast how this
I'll wait for this
is different.
contraction.
Yeah.
Yes. Yes. So you tried
Of course.
to serve. Okay. And when you tried to serve, did it hurt immediately, or did all?
So the clinical lessons learned: look for the asymmetries within either limb as well as within the limb, as far as the development of the muscle tension and areas where there's like non-uniform muscle contraction even within the same muscle. Secondary to that, recognizing the inhibition that actually comes secondary to injury, particularly around the patellofemoral joint, and then the considerations for deviating from the status quo of how to properly apply the NMES to get the more functional and normalized vector of force of the quadriceps. Not a complete solution, but a necessary step in order to make a full recovery.